channel. Hopefully, as soon as we have the practice and policy group channel, they will post their own material in their own channel. So right now you can see that we have the last webinar on that channel, and we have received more than 700 views, and that's perfect. That we have been able to kind of receive that level of attention from people across the board. Okay, Alex, we are ready to start. If you want to,
okay.
Let me just bring up your slides.
So, yeah, thank you very much, Hamed, Parnian, and the team. I'm sure you all agree. Right now, 1 week feels like a long time, and this is one good example of how much you could do in a week or in a couple of weeks. Because since the first webinar that we had about 3-4 weeks ago, the Practice and Policy Interest Group was not in formation at all, but we thought, as part of the International Society of Addiction Medicine, we thought, Hamed, I don't have the slides there, so that's why okay, thank you. We thought that it would be opportune, using the current momentum that has been picked up as a result of the COVID-19 and this relationship to our patient population, the substance using population, that we've put an application to the ISEM Board of Directors 4 weeks ago, which was approved with a view of forming this interest group. And as Hamed had said, it's in the context that we have currently 3 functioning interest groups within ISEM: the Neuroscience Interest Group, led by Hamed and Antonio Verdaja Garcia, the Behavior Addiction Interest Group, led by Mark Potenza and Henrietta Bowden-Jones, the Spirituality Interest Group, led by Mark Galanter and Greg from New York. And together with the Practice and Policy Interest Group, we are also seriously considering putting an application for an anthropology, philosophy, and/or human science interest group. And they reflect very much, the discussions, conversations that we have with practitioners and researchers, with a view of, with a purpose really to increase and improve the capability and capacity of addiction medicine, in order to pursue further, in this case for the PIG, the practice and policy related research and education, which will reflect itself at the end of the day in improvement in clinical care. Next slide. So what we did in the last 3 weeks, we did invite individuals, leading experts, and also international organizations, if they would be interested in joining the PIG. And I'm glad to say that we have about 25 core members of the PIG. PIG with double P, by the way, and they span from all over the world. We also have as members the WHO, the EU, and ODC. Thank you, Anja, for your email this morning, and also the EMCDDA. Thank you, Marika, for that. So in a sense that, this critical mass of practitioners will be able to look at pertinent issues and be able to influence international policy, and hopefully by doing that, influence national and regional policy. So this is accomplished through joint publications, agreed consensus, mobilizing international funding resources through collaborative research, and also producing informed educational materials. We are not replicating anyone's excellent ideas or processes. We just want to add value, and using the ISEM core values, we want to improve collaboration with other organizations. We want to team up. We want to make something better, but at the end of the day, we want to make something that is really ecologically valid, really practical, and from a practitioner's point of view. And again, cross-cultural, cross-cutting, and we are not, in favor of any schools or philosophies around in the field of substance misuse. We embrace all types of different disciplines, all types of different issues, pharmacological and non-pharmacological. And hopefully by doing that, we would be able to look at how we can improve our clinical practice and also test new models, which, COVID-19 is basically, pushing that forward very, very much. So since the last 3 weeks, next slide, please, the Practice and Policy Interest Group have 2 interim chairs, and that is Christos Konstantides and Shalini Arugunara, who are participating in this webinar. We also had a review paper, a position paper, published in Basic and Clinical Neuroscience, and most of you are also aware that there is a global survey going on right now through the Practice and Policy Interest Group in order to understand the practitioners' views and challenges and also solutions from a global perspective. And I'm glad to say that we have around 100 respondents for now, coming from around 80 different countries, spanning all over the world. So, this is just really an introduction. Everyone is welcome if they think they can contribute and make a difference. So thank you very much.
Thank you very much. The next speaker would be from UNODC, Dr. Anja Buse. Anja, we are with you.
Thank you very much for having us. So my name is Anja. I work with United Nations Office on Drugs and Crime, and let me really first congratulate you really for this excellent work on providing this platform for exchange. So what I'll talk to you about today briefly is the UNODC suggestions on services for people with drug use disorders during this COVID-19 pandemic. If I can have the next slide. Right, and just as you all remember, and these are data from World Drug Report 2019, at the global level, we have roughly 5.5% of the adult population that have used at least one internationally controlled substance in the past year. And of those, more or less 35 million people would be in need of drug use disorder treatment, but only 1 in 7 actually has access. And the situation is worse for women. Next slide, please. You maybe have missed now in these weeks of the pandemics and the lockdowns that we've just launched again with the World Health Organization the revised version of the International Standard for Treatment of Drug Use Disorders. And actually many of you have contributed to the field testing, and those kind of give guidance at the system and at the service level on what a continuum of care for drug treatment would look like. But obviously right now the question is if and how that can be realized under the conditions of the pandemic. Next slide. Next slide. Yeah, right. So, and I mean, what we're hearing from our field offices from all around the world is that challenges are increasing, and you have already shared similar in the last call. So what we are hearing is that sometimes treatment services are not considered as part of the critical or the essential health care, which means that getting access to protective equipment is much more challenging. We are hearing about shortages of medications for pharmacological treatment. We are hearing, and of course, residential services need to adjust their services, that there is reduced access to those. We're hearing moving to telemedicine formats like in versions we are doing here. You know, it's very difficult when there are no stable internet connections. We're hearing about people using drugs moving to more risky modes of consumption, given shortages of drugs in parts of the world. We're hearing how curfews are affecting homeless people, including people who use drugs, and that ensuring livelihoods is becoming a growing issue. And also for people in contact with the criminal justice system, we're hearing that not everywhere where actually these compassionate prison release schemes are used or alternatives to conviction or punishment are increased, that often enough people with minor drug-related offenses are not included in such schemes. Next slide. Right, so what UNODC is also doing right now, and in a way similar to what ISAM, the questionnaire was just mentioned, we have also reached out to our member states around the world with the help of the UNODC research section, and we're asking about the impact that COVID-19 has, including on drug treatment related services, or the indicators that I put there, like number of people receiving services, overdoses, and so on. And we will also go out with an additional questionnaire, so I'll look out for that, where in addition to that, we will also be very interested in collecting good practices. So what things have worked already well in terms of adjusting services to the challenges of the COVID-19 pandemic. Next slide. Right, and in terms of health system preparedness, of course, the World Health Organization has a lead in the UN system. And if you have not seen, I just wanted to point you to these kind of free resources that exist in many languages. These are free training courses on WHO website. And I think they're also relevant for treatment services. So I think it's worth having a look. Next slide. But coming now to the UNODC guidance that we published, I think, 2.5 weeks ago about suggestions about treatment, care, and rehabilitation of people with drug use disorders in the context of the COVID-19 pandemic, which is, let's say, our contribution to the health security of countries and communities. And obviously, you know, in terms of support of member states, those are available on our website currently in 12 languages. Next slide. And just these are kind of 9 suggestions that we've put out there. And of course, happy for your comments and questions on those. So the first, of course, is that we need to address continued access to treatment services, and such being included or being considered as essential health services will help. And also, of course, having contingency plans, like many of you shared already in the last call, is going to be key. Next slide. And in order to keep services open, of course, we need to address the safety of staff and the patients. And again, many of you shared how this is being done by changing how services are organized in terms of physical distances, how services are being delivered, also how maybe staff schedules are being reorganized and all of that. Next slide. And to keep the premises clear and clean and hygienic, of course, is part of basic safety. Next slide. Another kind of recommendation there is to provide accurate information to all people.
I would really love to meet up with a big, well-hung black guy. I just have a fantasy about black guys. I want to have one of them up inside me. I want to taste them and touch it, be used.
Was hearing some radio? No. Okay. Okay. Sorry.
Share me with your friend.
And to provide accurate information, I think. So next slide, there was some interference around. Next slide. And another suggestion in our guidance note is a continuity of low threshold services to not lose the contact with people who are using drugs, including those on the street or not in treatment at the moment. And not to forget about emergency overdose prevention schemes and access to other health and social low threshold services. Next slide. Right, and then one thing, and I think you mentioned also to look into the continuity of psychosocial therapies, so how psychosocial therapies or also peer support groups can be continued, and a lot of good practices on those we see emerging. Next. Yeah. And then the continuity of pharmacological therapy, and I think also in the last ISAM seminar, a lot of good practices were shared, how, so to say, through reorganizing services, take-home schemes, home delivery, or having other places where medication can be accessed, like in pharmacies, this can be guaranteed. And obviously not only for maintenance treatment, but also to think about how we offer medications for people with co-occurring mental or other health disorders, or for withdrawal management as needed. And as said, I mean, we see challenges coming up here as the stock for medication is limited in many places already. Next slide. Said already in the beginning, it's important to provide support to homeless people, including those with drug use or drug use disorders, but also to ensure access to continued livelihoods for people that maybe usually make their money more on a day-to-day basis on the street. Next slide. Well, and basically in summary, the message then is that under no condition should a person be denied access to healthcare based on the fact that they use drugs, have drug use disorders. So we also have to, let's say, keep our guard up with regard to stigma and discrimination. Next slide. Just this is one good practice kind of emerging from UNODC in Nigeria that have brought together health workers that have been previously trained over the last years by UNODC and that are now volunteering providing volunteer services in Drug Help Net, and providing psychosocial on the phone. Next slide. And if you're interested also in more information available for HIV prevention, treatment, and care for people who use drugs, this is the link to the website of our HIV section in UNODC. Next slide. And I just wanted to mention before coming to the end that there is also guidance available on prisons and preparedness for prison health services. And this is both from UNODC and WHO, one on prison health services, but also more on the justice side for these increased considerations around alternatives to conviction or punishment. And we see already a lot of examples of compassionate and early release schemes for people in prisons, and we hope for the inclusion of people with drug use disorders there as well. Next slide. So that's already basically coming to the end. I also want to point out that UNODC, together with UNHCR and the World Health Organization, has an initiative that dates slightly to before the COVID-19 pandemic on addressing substance use in humanitarian and relief settings, which of course has become very timely suddenly. So if you're interested in this or something else, so maybe it's just the last slide, then, I mean, here are my contact details. You can also follow our section, Prevention, Treatment, Rehabilitation section in UNODC on Twitter. And below you have the link to all our publication, including the recent publications on COVID and the new version of the International Standards for Treatment of Drug Use Disorders. So with that, just thank you very much. Really, this is an excellent platform, and we are very, very grateful for all the work all of you are doing around the world. Thank you.
Thank you very much, Anya, for being perfectly on time. The next panel would be some updates from the speakers from the first webinar that presented their national experiences. Now, after 3 weeks, they are going to give us an update about what has happened during the last 3 weeks and what are the things that they have accomplished during the last 3 weeks. Okay, the first one would be Susanna Gallia-Singer from New Zealand. Susanna.
Hi everyone. So in New Zealand, we're currently in alert level 4, which is eliminate. So we're in the 4th week of lockdown, which from a health services perspective, this means that people need to be at home, that addiction services have been considered as essential services, and so they will continue to operate. However, travel for every individual has been severely limited, and we have been reprioritizing our healthcare services. Next slide, please. So one of the first things we did was make sure that there was enough information for individuals using substances. And there's the New Zealand Drug Foundation that has developed a site, and this is what it looks like, which helps people understand how they can use more safely, how they can manage their withdrawal, maintain recovery, and other aspects that you can see over there. Next slide. So this website was developed in a co-design manner with a few users, and made it easy to use and easy for users to understand when they need to contact services and how. And this is again a snapshot of what it looks like. It provides them with a very clear message, what would be common symptoms of withdrawal, and what to do. Either stay at home, call your doctor, or call 111. Next slide, please. From a service provision perspective, because of the lockdown, we've been running virtual clinics, which basically means there have been no face-to-face primary or secondary care consultations. Largely, the provision has been community-based, which means a lot of telehealth, video consultation, and online support is provided. Consideration has been given to the pharmacological needs, but also the talking therapies. How do you provide talking therapies within a telehealth space or video consultations. Now, the Medical Council of New Zealand did come up with some guidelines around prescribing, and it did allow for prescribing of controlled drugs without having to see the person face to face. But you need to, of course, ensure that assessment is adequately done. In New Zealand, we have what's called, previous slide, please. What's called SACAT, which is a Substance Abuse Compulsory Assessment and Treatment Act. And consideration was given on an individual of requiring compulsory treatment. Again, some adjustments were made from a legal perspective to be able to do the assessment through video conferencing. Needle exchange services remained open. However, clear instructions were given to be able to maintain the social distancing. Virtual clinics, what are the challenges? So there's a lot of literature out there around virtual clinics, and we do know that they work, and we do know that they're associated with quite a lot of high satisfaction rates. However, what we don't know is how do they work for new clients presenting to services, or those in acute distress, or those with complex problems such as cognitive impairment. And also, most studies report on virtual clinics when they're sitting or running alongside traditional face-to-face clinics. Now, this has not been possible during COVID-19. So once again, we're not sure about the effectiveness of the virtual clinics. Previous slide, sorry. So what New Zealand has done is it's provided opportunities to share good practice. So a number of national bodies have been getting together on a weekly basis and sharing ways, talking about the how do you do things in order to develop effective virtual clinics. Next slide, please. So one area that we're currently really focusing on is that we need to take care of our essential workers. And it's not just about providing the appropriate PPE, but also about the welfare of our staff. And often you find loads of websites with a number of resources in them, but we're providing perhaps an overload of resources without helping our healthcare workers go through what they need to be able to keep themselves well for their well-being. So currently we're working on making sure that there is a good framework for people to be able to access those resources. And the last message that, you know, are the people we deal with, people with alcohol and drug problems, there's a lot of stigma, as we know, and be kind needs to be the message for everyone.
Okay, thank you very much, Susanna. The next speaker would be Gulare from Iran. Gulare, are you online? We cannot hear you, Gulare, right now. Okay, let's move forward to the next speaker, Fatima from Norway.
You are hearing me?
Yes, very well.
Yeah. In Norway, the government of Norway has announced that the situation is now under more control and the curves point downwards, but it doesn't mean that the crisis is over and the measures is going to be continued, but it is in accordance to the situation, which is changing all the time. In Bergen and in western region, we have still not recorded infection among our patients or staff, and no admissions to the new interdisciplinary COVID-19 bed unit we have in our department. which is in accordance with the lower in numbers of the infected people. And from our inpatient care services, we know that surprisingly, almost 50%, we have almost 50% decline in admissions due to withdrawal intoxications or overdoses in our emergency and detox units. And we have not noticed that drugs are less available in the illegal market. Remarkably, yet, except for the cannabis, which has been lower access also before the pandemic started, and also to some extent for benzodiazepines. And we think that the number of admissions indicates a decline in the proportion seeking help. We don't know why, but some people tell us that they are afraid and worried to be infected or infecting others. And of course, we are more worried about the homeless patients who are not normally easy to follow up. And at worst, we can have a situation with more sick people and deaths afterward, but we don't know yet what is the reasons to lower overdoses and the intoxications yet. And from our outpatient OST clinics, the situation is more stable. We have focus on remote consultations mainly, and home delivery. And the patients are more stable and cooperate. No experiences of increased withdrawal intoxication or agitation in the patients visiting OST clinics. No agitations against the staff, but some small reports on violence and stealing inside in the some environments. And we are worried about the patients with psychiatric comorbidity, observing them become more worsening their condition in terms of psychosis symptoms and more admissions in the psychiatric unit, which are worrying, and we have to follow them. And now and the reasons for that. But the good thing is that we have more. Hello?
Yes.
Yeah.
We are just.
Yeah.
We are just.
But can I continue?
Yeah. Sure.
Yeah.
Just. Yeah. Please.
But just 1 minute. And more individuals are applying for OST, especially through our low threshold walk-in clinic. This is a good thing, and we have a close cooperation with the interdisciplinary overdose prevention team and municipal harm reduction teams, providing help to the patients. And our national local guidance are changing in accordance with the situation. Right now, we are in process in our department developing medical routines and an algorithm in the case of a possible shortage state for illegal drugs, which is more complex process. And I suppose that Christian will tell us more detail about it later. And we see that we have had more stricter measures, which is it's possible to do something and to dissolve some of these stricter measures, but continue to have them in different stages in accordance with the situation. And we see that it's more important to have a closer collaboration between the different sectors across the specialist primary health services, municipal services, and peer groups and the police. Thank you.
Thank you very much, Fatima. So the next panel would be international best practices, and I kind of ask all the speakers to be really careful about being just on time for just 2-3 minutes. It's going to be like a rapid chess. So please kind of be careful about the timing of your presentation. Okay, Kor, you are going to be the next speaker. Kor, we cannot hear you.
Do you hear me now? Can
Yes.
you hear me now?
Yes.
Yeah, okay. Well, I said I'm a medical doctor and a psychotherapist, and I'm always interested in the micro level of communication with patients. So I came to this slide and some research. It takes two to tango, the Therapeutic Alliance in times of Corona. And we wanted to know, because we know that this kind of epidemic affects us all, and it affects the patients with substance use disorders, but it also affects healthcare professionals working with patients. So my question was, does it affect also the Therapeutic Alliance? And if so, what went wrong? And if it's wrong, what can we do about it? So we together, you can see Cornelis de Jong, my wife, Janine de Jong, Robert Pols, a peer supporter, and Cor Brugge, a nurse. We did a quick and dirty interview with 13 patients based on the cognitive behavioral therapy aspects, thoughts, feelings, and behavior. And we asked them, how does the Corona crisis affect you, your environment, your problematic use and addiction, your environment with regard to your problematic use and addiction, and your treatment and your contact with your therapist. So we have now 13 interviews, and I will not summarize them, but I will give some quotes that came from all those interviews. So how does it affect you? Well, a patient said, I think I can get COVID just like that. Or I fear of getting ill. I became angry at people because they don't stick to the rules. Or they stay at home as much as I can. And the environment, my partner pretends that nothing is wrong yet. They look at me as if they say, don't worry, use, has it any influence on your use? Some says, yes, I use more. Some say, well, I use less. It's difficult to cope with craving. And on the other hand, no parties, no craving. And the environment and use, most of the people said some are concerned in my environment that I will start using it again, that I will relapse, etc., etc. And the most interesting thing is that concerning their treatment, the treatment changes. We heard a lot of changes, virtual clinic and so on, but it changes. And I do have less sessions. The opioid substitution treatment is far more complicated. There's no direct contact. I miss the face-to-face contacts. And then to the Alliance itself, more or less, your contact with the therapist. Well, they are talking most about rules that are changed. And the nursing staff worries especially about themselves. I noticed from this behavior that a lot is going on with them. They seem to be insecure, powerless, and stressed. Therapist doesn't talk about the effect of COVID on me. They neglect the whole situation. They're talking about dosages and the cognitive behavioral therapy online, but not what it does for me. So our conclusion so far, we are writing it down, try to write it down. In general, patients seems to have the same thoughts, feelings, and behavior as we all have. It influences their use, sometimes in a better way, sometimes in a worse way, and it influences the treatment generally in a negative way. And patient noticed that their therapist seems to be more vulnerable in all sense, and it seems that they need more from therapists in times like these. Well, this is what we found out from 13. I think we do not have to ask more people. We do try to make some guidelines, a tool that you can think about how to discuss the effect of the COVID epidemic on the relationship, on the patient himself, and what it does it mean for you. So that's what we have found so far. I think 3 minutes.
Perfect. Fatima.
Thank you, Hamid. Thank you for this invitation, and thank you for asking for the situation in Morocco. So in Morocco, in order to comply with health containment, we noticed the need of reorganizing our addiction treatment facilities and the need of changing our medical prescribing habits. So the Moroccan Association of Addictology proposed for Moroccan professional guidelines during the COVID-19 pandemic based on the local reality of psychoactive substance use, Ministry of Health policies and politics, our clinical experience, as well as the national and international debate around the issue. So guidelines for the next, please. Next slide, please. Yes, so guidelines for health professionals, for example, for to reduce time in ambulatory face-to-face consultation are reduced and maintained for situations requiring immediate care, in particular for new patients, patients with opioid agonist treatment, and patients in emergency situation. And we telemedicine by using virtual session via phone and call remain in our practice an effective link and facilitate the patient follow-up. In this case, medical prescription is sent electronically, and the digital platform and video conference call is provided for keeping group meetings and self-support group like AA and NA. This is good because it keeps out the social link and the risk of complete and avoid the risk of complete isolation. For inpatient detoxification unit, hospitalization appointments are delayed during the pandemic. And for the methadone treatment in Morocco, we are aware about the need of not stopping this medication during the pandemic. Daily methadone deliveries are replaced by more take-home dose, and the stabilized patient take 20 dose during this pandemic. And healthcare staff call patients at least once a week, and patients under opioid agonist treatment who are not resident in Morocco but are currently in the country because of containment, access to for free to all methadone treatment centers. Concerning drug users, general recommendation related to the prevention of coronavirus and the risk of infection by using drug are clearly provided to all patients, and we invite them to contact centers and their doctors or nurse and keep taking medication. And we made also a few podcasts to help patients coping with psychological distress of containment and to promote a healthy lifestyle. About harm reduction, we keep NGOs, national NGOs, keep giving it. They keep providing safety material of injecting drug use, screening for HIV, for example, preventing overdose, giving psychosocial support, and making home visit to patients. Hotlines also have been created. It's kind of phone assistance, and professionals are supporting substance users, patients who have addiction and their family during this period of containment, and they give daily listening phone call, medical orientation, psychological support, and follow-up. And thank you for listening to me.
Thank you, Fatima. The next speaker would be Shen from China. Shen, are you online? Shen, could you hear us? Okay, we cannot hear from Shen, but it might be interesting for others that in China they have developed a specific protocol for substance use treatment during COVID-19, and we have added that protocol. They kindly translated the entire protocol from Chinese to English, and we have added that protocol in both Chinese and English in the kind of the ISAM COVID-19 repository. So those who are interested to kind of see what is happening in China, they can have access to that translated protocol into English. Okay, the next speaker, Christian.
Good morning, everybody. I will focus on concurrent disorder treatment during the COVID-19 pandemic. Next slide. Obviously, the focus has to be on minimizing the disease transmission risk, and that means we need to adapt to the treatment and support. And I will focus on 3 major points. Can you please next slide? The first is the implementation of new organizational structures. Changing a lot of changes needs to have a lot of information exchange. So we have a daily emergency operations center meeting every morning for at least half an hour. Additionally, we meet regularly, like probably up to 6 hours per day, just to discuss the different changes. Because changes are coming from different levels too. We have the federal level, like Health Canada, coming out with new standards. We have the provincial standards. We have the standards from the health authorities within the province, and then we have the different colleges and so on. So there's a moving target constantly, and we need to adapt our organization accordingly. One big thing, for example, is we have completely changed our intake. Next slide. And based on this new information, we have been developing procedures on a daily basis almost. Next slide. For example, our intake has been changing completely. Instead of having individuals coming in, we now have like cohort intake. That means we have a group of 6 people coming to the intake, staying together for 2 weeks before they move on to the next intake. So that also means we had to reduce our intake and we had to adapt our kind of clinical care, but we have been trying to develop safe practice throughout. And we have overall like 65 different treatment groups. Next slide. And so we had to also adapt our treatments. What it meant is that each single group we had to think about being mainly group-based. What can we do to change these groups? There were different groups, from standardized CBT groups to cooking groups to acupuncture groups and so on. And so overall, the process has to have smaller groups, have shorter groups because we need to provide more groups, then also provide more material. We have to adapt the communication. So we have been buying tablets so that individuals can communicate with their family, because we are not having family access anymore. Overall, this had meant that we needed to really kind of develop, I think we have developed by now 40 different procedures. These are often very simple things. For example, one of the problems we were facing was that we don't have hand sanitizers available in our center, because we have a lot of people with non-beverage alcohol dependence, and they have high risk of drinking the sanitizers. So we had to really focus on hand washing and having the hand sanitizers available for staff at the same time. So there were a lot of adaptations, starting not only from the overall structure, also the nursing cannot move between the units anymore. So we have to kind of change the nursing procedures. And this is ongoing on a daily basis. So what really has happened is that the communication level has to increase. It's actually one of the big problems we are facing at the moment is almost an information overflow, because we are getting information from all the sides, and it's hard at sometimes to really kind of stand up on top of these information processes. Next slide. So I already kind of indicated that Health Canada has changed the prescribing patterns. So we now have prolonged prescription over 30 days. You can have early refills. You can do verbal orders to the pharmacy for controlled substances, which you could not do before. You can have delivery of methadone and other restricted controlled substances, which we could not have before. So safe supply has one of the focus in changing the prescribing patterns. And for us, the main issue has been really kind of the maintaining the program, which is really based on interaction. So one is the group program. For example, we are now providing groups in cafeteria and outside, just because we have a problem with space. We have adapted our contingency management, brought more to kind of also include good, so to say, behavioral patterns, and have increased our telehealth capacity. I did put a few online resources on. One is from Health Canada about the methadone prescription changes. One is the recommendation by the BC Centre for Substance Use regarding safe supply. And the last one, which is also important, is the dealing with the overdose crisis. Our BC CDC has made recommendations. Actually, we currently see an increase in overdoses here in British Columbia in the last few weeks, after we had seen a reduction in the overdose actually last year. Thank you.
Good. Thank you, Kristen. Now, experiences from Australia. Shalini.
Text. So time around the person they've been a little symptoms of and the current stress to give me case
I actually don't understand anything. I don't know if that everybody has the same problem.
It's difficult to hear you.
Yes, Shalini, it's difficult to hear you.
Yes.
Shalini, we cannot hear you.
Unfortunately, it's not hear you very well.
Yeah, I think that we have problems with Shalini in terms of the internet connection. We can move forward and have the next speaker. Then, Shalini could just fix the internet connection, we can get back here.
Ahmed, would you please suggest Shalini to change the microphone?
Yeah, Shalini could try the other microphone. So let's move forward for the next speaker, Eric Perron from France.
Okay, so thank you very much, Ahmed and Alexander, to invite me to this meeting. So I am Eric Perron from France, and we are working in an outpatient unit. And with the COVID pandemic, we have to change many things in our care. The first thing we have to do is that the patient have to stay at home. So we change absolutely everything. And all the patients have now individual and group therapy at home. And so we are trying to have every week contact with the patient, and the patient can have individual therapy every week or group 1 or 2 weeks, 2 times a week. And we are following more than 250 patients. And of course, patients can have a different type of therapy, CBT therapy, psychodynamic therapy, mindfulness therapy, body therapy, and relaxation, everything. We change all the therapy and in 2 ways. First, to work on the stay-at-home situation. It was very important to develop special therapy on this point, because it is a craving situation really for the patient. And also we change all our CBT therapy or other therapy in very short session, in order that the patient can directly have the solution of the situation. So it is the way we are doing things. The most important difficulties we thought that we could develop video therapy and things like this. And unfortunately, most of the patients have internet, but they don't know how to use it. And so we took the decision to have only telephone therapy. And that's it has been a very big difficulty for us. We didn't know about it, but we have to do it like this. So, and we are working on two program research. First program we are doing now, it is how the patient feel during this quarantine period and how this period can influence their addictive behavior. First, I just want to tell you one thing, that we are working with patients with addictive behavior. It is mean that we have alcohol, non-alcohol, food patient and all things, and we all have a group of different product problem. So the first program of research will be on the quarantine period and the consequence on the addictive behavior. The other program we are building, it is to research on the behavior after the quarantine period and the consequence on the behavior, addictive behavior. And also we are working now on human science research in order to see how this pandemic period can change the alliance therapy with the patient. And we will have group of reflection with philosophy, sociology, and anthropology. Thank you very much for your attention.
Okay, thank you, Eric. Gelare, could you hear us right now?
Yes, I can. Since sometime, I'm so sorry. I was just writing and emailing, and I fully forgot about the time. So I'm very sorry.
Okay, your slide is up, so you can just present your slide.
Okay, good. Yes, as you or those who were in the previous meeting may remember, we had developed at that time a brochure, and we were thinking of bringing it out. We had done some preliminary coordination with a number of NGOs and the Iranian Drug Control Headquarters and the State Welfare Organization. So during this period, we managed to bring out the brochure that we had developed on prevention of COVID-19 among people who are using drugs on the street, homeless people. And we played the podcast, we distributed brochures, and it was very well received. The podcast everybody likes very much. And the NGOs were independently doing, that is, we were doing a combination work together. So they were taking our podcasts and brochures to the field, but at the same time, from their own resources and from some resources provided by the State Welfare Organization, they were providing soap, disinfecting material, masks, food, because that is also very important that people don't hunger, and all these to this hotspots. And this joint collaboration seemed to be very successful. About 1,800 people on the streets were approached in the city of Tehran. We also have sent some 300 brochures to Arak. This is another city in the central province in Iran. So anyway, it seemed that things are going are rolling out well. The main problem that we are still facing in the field and is going to be resolved, there are some actions to mitigate this barrier, is the limitation of people to access water in the hotspots. So that really is a barrier to hand washing and makes it very difficult, because if you don't have water, simply you cannot wash your hands. So also on that, the NGOs are now thinking of bringing some containers, tankers to the field, and they're also some of the NGOs liaising with the municipality that public toilets and washrooms are opened in the parks because they're closed because of the quarantine of corona, within this respective of the fact that there are people living on the street and they cannot quarantine themselves simply because they don't have any roof. So that is ongoing, and we also published 2 short web stories on our website. So that's from my side. Thank you for your kind attention.
Thank you, Galara from Iran. Okay, I'm not sure if Shalini was able to fix her mic. Shalini, could you retry your mic?
Does that sound okay? Can you hear me okay now?
Yes.
Yep. All right, people are nodding, so I assume it's okay. So I'll go back to my slide. Let me know if this doesn't sound okay. Great. So just briefly, I suppose, touching on 2 things, 2 key points in Australia. So we've been through similar phases, certainly in New Zealand and a couple of other countries. We have a stage 3 lockdown, and what that means is people are only leaving the home for essential services. We've made a transition to telehealth, and so across our services, drug and alcohol treatment here has been considered and being delivered by telephone largely. The caveats here, I think, I just wanted to touch on a couple of key points for us that's been tricky, I suppose, to resolve. We've had some regulatory flexibility around opiate treatment, and so we've certainly had changes in legislation around unsupervised dosing, flexibility around pickups, third-party supplies, so someone else can pick up if you're on isolation. What we are struggling with to some extent is injectable treatment and the logistics around offering buprenorphine as an injectable treatment on a larger scale at this time. For patients, it would be clearly preferable to only need to attend a service once a month to get their opiate treatment through Buvidal. And the problem for us is in exposing the vulnerability system in terms of capacity and capacity. You think about the instance that we've had very high testing rates. As a result of high testing rates, workers have been tested properly, and it means that cold and flu in isolation. So in healthcare clinics normally offer Buvidal or other injection treatments in isolation. There's ability in terms of model of injectable treatments more broadly, where it's less about necessarily patient preference, more also about service capacity and service logistics, being able to have that as sustainable. I think the country are looking.
We have problems with your kind of audio. Would you just turn off your video, just getting sure that you will have enough kind of bandwidth to receive your audio?
There we go. So in terms of preparation at the moment, I think what we're mainly preparing for is mental health being a real priority during this period. We're expecting that current treatment are going to be experimental. Emerging population of individuals be vulnerability of employment,
Shalini, it seems that we have problems with the phone. The good thing is that at least we have the slides and we can see what is really happening in Australia. We can definitely kind of go back to you after the having other speakers and see how we might be able to kind of give you time to present the updates from Australia. Okay, now we already have Dr. Kathleen Brady, president of ISAM. I think that kind of Kathleen it would be nice if you kind of say hello, and also if you introduce Nora Volkov, that would be perfect.
Okay, that's great. Thank you so much. Thank you, Hamid, for organizing all of this. It's really, I'm just impressed that you guys it's such a nice, large group of people representing so many parts of the world. And it's just wonderful to share information in these really stressful times. But what I'd love to do is introduce to you, I'm so pleased to introduce Dr. Nora Volkov, who, as you all know, is a brilliant scientist who has been the director of the National Institute of Drug Abuse here in the United States for the last 17 years. And she has really just raised the profile and the scientific portfolio of NIDA tremendously, addressing neurobiology of prevention and treatment, and really, in addition to the neurobiologic aspects, really the behavioral aspects. And in this critical time, this isn't the first time that Nora has really spoken out about stigma and the impact of stigma on the patients that we treat. And I just want to say that in her usual really proactive and just spot on manner, within days of it becoming so apparent that this pandemic would really have an impact on the people that we treat and the people that we care so much about. She had written 2 brilliant editorials, I think, that addressed a lot of the things that people have been talking about on this call today, how we can provide the best treatment in these extraordinary times for our patients. So I'm going to turn the stage over to her. Thank you, Nora. I think you may be on mute. I think you're still on mute, Nora. Yeah, each one of these meeting platforms.
Okay, can you hear me, guys?
Yes, that's it. Perfect.
Yes, I see it green. Well, thanks very much, Kathy, for the very nice introduction. And Hamed, thanks very much for organizing this. This is quite wonderful. And I think it has taught us this horrific experience that we're seeing, that we can embrace technology very rapidly when we need it. And we are getting aware about how powerful it is. And to me, one of the things that I see fascinating about the forum that you are generated is the ability to learn from each other, from our experiences in very different circumstances very rapidly, so that we can all benefit. So I've been obviously very, very concerned about the fact that we have an opioid epidemic in the United States, and then we have this tsunami of the COVID pandemic, and these 2 things are happening at the same time. And so what are the consequences of that intersection? Because this is a very new phenomena, the COVID, we don't really know. So we're exploring a new world, and hence the urgency to learn rapidly. But we do have knowledge about physiology. We have knowledge about what drugs do. And that, of course, is of great concern. So who advances my slides? Next slide. Do I do it myself? Yes. So here we have. Certainly, we are primarily sensitive to the notion that COVID is a disease that is manifesting itself by acute pulmonary insufficiency. And we do know that many of the drugs that people take actually are harming the lungs as one of its main targets. And of them, the most notable, of course, is smoking. And we do know that, there's not enough data. And if you look at the literature, you'll find out that, yes, in general, smokers do worse, actually, but we don't have the sample size to say unequivocally they do worse. They have much worse outcomes. But the numbers are clear, and it follows that because chronic obstructing pulmonary disease leads to worse outcomes and smoking leads to COPD, that will actually be one of the mechanisms about why there is pathology. At the same time, we know that most people that have substance use disorders, a very high percentage of them are smokers. So regardless of the drug they are taking, they're going to have that vulnerability brought up by the pulmonary damage from smoking. We don't know much about vaping other than it can produce acute pulmonary injury, EVALI, and can result in death by itself, presumably from chemicals in the vaping that the persons are consuming, certain chemicals. But we don't know what are the consequences of hours of ingesting high temperature vapors into your lungs and how that actually will interact with the virus. We do know in animal models that the vapor itself can produce inflammation, and hence the concern, whether you are smoking cigarettes or marijuana or you are vaping, that in and of itself is going to increase the risk of adverse outcomes. Then we know about other drugs. I mean, what do we know about opioids? They produce respiratory depression. And when we decrease the breathing, the ability of the lung to actually properly extract oxygen for delivery into organs is actually undermined. And ultimately, that's the cause of death with overdoses. But what happens if you are taking an opioid? And here we have to also be consistent with the notion that, well, how does that even relate to issues like methadone or buprenorphine? To what extent there could be an interaction? Now, of course, we know from work already published in the past that if you are a heroin user, you are much more frequently hypoxemic than even if you're taking high doses of methadone, because you become tolerant to the doses of methadone in a consistent level. But understanding that dynamic is going to be fundamental as we actually try to help our patients and ensure that they are covered both for the opioid use disorder, but if they get infected, how that interactions plays around. Methamphetamine use or cocaine use are likely to be harmful in and of themselves because they are vasoconstricting drugs, and we know that. And one of the problems that leads to the pulmonary damage in COVID has to do with vessel leakages. So to the extent that we have drugs that are directly producing vasoconstriction, we have to be concerned about it. And we also know that methamphetamine is one of the causes identified to produce pulmonary hypertension. So you put 2 and 2 together and you say that's likely to be a very, very bad combination. Now, like anything else in life, there are surprises. And there is a paper that was published, I think, like 4 years ago, where they actually show methamphetamine as well as amphetamine, which are alkaline compounds, can go into the vesicles in cells and actually in that process interfere with the infectivity of the virus. So in vitro cells, both methamphetamine and amphetamine were shown to have a positive effect against interfering with the virus. But overall, this was in vitro, and in vivo, we do not know what ultimately the outcomes are going to be. Regardless, we do know that drugs produce tissue pathology, multiple organs, and that's likely to put individuals at greater risk. But the research is not there to understand how these interactions are going to progress, and we have an opportunity to obtain it. Then, and next slide, please. So this is in terms of the physiology of what these drug pharmacology are doing. Next slide. It's not letting me pass my own slides, so I need someone to pass them. No.
Hamed,
do you know, can you pass the slides? Hamed, someone can pass the slides, guys. If not, I'll go without slides because I cannot. Here it is. The other components of it have to do with what I call, there is the pharmacology, and then there is obviously the structural systems that we're working with. And stigma is a horrific thing that we are actually going to see emerge its ugliest head. Why? We're already in the situations where people have to make the decisions of who's going to get a ventilator, who's to get priority. And we do know that people with substance use disorders are stigmatized. They're stigmatized because of the belief that they did this to themselves. So the healthcare system that is already very stressed under very adverse conditions is unlikely to be in the best state of mind to understand the unique needs of individuals with substance use disorders. And we need to communicate this, and how we actually navigate this in the healthcare system is very, very important. And I interviewed yesterday, and they kept on saying, but isn't it people that are taking drugs, putting others at greater risk to be infected? There is already that narrative going on, and we have to be proactive to stop it before it starts, because a person that has an addiction to drug is not at greater risk to others than anyone else. And you all have been discussing it, and we already know that the ability of the healthcare system to provide access to medications for opioid use disorder, namely buprenorphine, has gone down. And we were discussing with some PIs, approximately they are seeing a 20% reduction in their ability to provide care with people. From the emergency departments, what we're hearing is that there has been a decrease of patients that end up in the emergency department with an overdose, presumably because if they are reverted in an overdose, they are actually not being brought to the emergency department. The other big concern is that the social distancing is going to increase the likelihood that people actually have, if they overdose, it will be an unobserved overdose. And hence the ability to give naloxone is going to be much lower, and the likelihood of survival is going to be greater. And two, the notion of the erosion of the community support systems that we have, whether it is syringe exchange programs or the methadone clinics, are being undermined, and this is leaving people at a much greater disadvantage, which leads me to my next slide. Next slide, please. Next slide. That the element of ultimately, when we're dealing with addiction, considering that there is not an homogeneous person that's addicted, that the circumstances of people that are addicted are very different. And in some instances that actually, there are some that are even more vulnerable than the others. And the two ones that jump immediately into our brains are people that are homeless and people that are in the justice setting. Why? Because both of them are the greatest risk. And in the homeless population, we already address, we've already been very aware that it's very difficult to actually keep someone that has housing stability in treatment. So now when the systems are actually overburdened, how do we provide that support? And how do we protect them from getting infected? The same problems, actually different problems, but as challenges in the justice population. The jails and prison systems are actually extraordinarily crowded, are open for focus of infections. Many of the prisoners, some of the prisoners are being released into the community with not support, and therefore the risk of relapse and overdose are very, very high. These are major challenges that we're all facing. We do research, and we're trying to actually encourage researchers to come in with supplements. We want to be able to use this moment to garner information that can lead us to implementation, to testing of digital health technologies, to assessing the value of these new tools, to monitoring the response and retention in treatment when we're using extended release medications, to understand the interactions. And so we're putting in supplements. Next slide. And that's my last slide, which advertises, keep it because it's I don't know why they put it in a motion. Move it again, put it, well, anyway, there's supposed to be, if you hit the thing, there's supposed to be a tsunami that's coming with the COVID, but the important notice is up there to actually tells you our urges, if you are in a unique situation that enables you to obtain information and you need resources. We now have a notice of special interest regarding the availability of administrative supplements and urgent competitive revision for research, so that we can understand better how to address the needs of patients with substance use disorder amidst the COVID epidemic. Now with that, I thank you for your attention. Thanks very much.
Thank you very much, Nora, for the inspiring presentation. Okay, the next panel, we will have 4 speakers for specific issues regarding the substance use disorder and COVID-19. We will start from Judson Brewer from Brown. Judd, could you hear us?
I can, and it looks like my all the cameras are in use, so if somebody can drop off the camera, you can see me, otherwise it's not a big deal. There we go.
Okay.
Great. So I know we just have 3 minutes each, so I was going to just jump in with some of the psychological issues that we're seeing with the emergence of this pandemic. Just to remind everybody, fear is a basic survival mechanism. We learn through fear, through reinforcement learning. You know, if we step out into the street, we almost get hit by a car. We learn to look both ways before crossing the street. So that's a very basic survival mechanism. On top of this, you know, we can think of our neocortex and our prefrontal cortex in particular, which are involved in thinking and planning. Those actually need accurate information in order for our prefrontal cortex to work well. So in the emergence of this pandemic, where there are very many unknowns, this is a huge risk factor for folks, where this uncertainty plus fear actually leads to anxiety. On top of this, we see, you can prevent the spread of a virus by social distancing. If you go on social media, you can actually spread fear, anxiety, and even panic through social contagion, which is just the passing or the spread of affect or emotion from one person to another. So it's just really important for folks to know these things and see how all of these can actually spread contagion in those ways. So what can we do about this? My lab studies mindfulness training. We've heard this in previous presentations. One of the main things to keep in mind is that anxiety and stress are one of the big risk factors for relapse. Dr. Volkoff already mentioned that. And there's this acronym that many of us probably know, which is HALT. When we're hungry, angry, lonely, or tired, those are the times when we're at increased risk. And the way I think about this is that people with substance use disorder or history of this actually have a higher risk there, but also the general anxiety level in the population is rising. You can think of that because of just the general uncertainty that's spreading through social media and whatnot. So what can we do? I've been putting out daily videos on my YouTube channel to give people short mindfulness practices. If those are of interest to patients, that's a resource. There are many resources and very simple ways for people to simply ground themselves in their present moment experience so they can actually keep their thinking brain online and thinking. So whether it's encouraging people to take a few short breaths, to ground their awareness in their feet, to take a short mindfulness practice for that to help them, really ground in their present moment experience, that helps them keep their physiology calm down and their thinking mind online so that they can think and be less vulnerable to relapse.
Thank you, Judd, very much. The next speaker would be Julia Sinclair from UK. Julia.
Hi, Hamed, and thank you. So I was going to take a slightly different approach to this in terms of thinking about kind of some of a population-based approach. And we've been talking a lot today about much more the addiction specialists. So I'm currently chair of the Royal College of Psychiatrists Addiction Faculty. And it's that, I have to make clear that it's that capacity in which I'm speaking rather than as the National Specialty Advisor for Alcohol Dependence. So obviously that's for England, which is only a smaller part. So that's my disclaimer out of the way. I think the key bit, if I have the proper slide, would be super. The next slide, yeah, super. So I think where we came at this is that we already have fairly reduced resources for patients with addictions within the UK at the moment after many years of reductions of fundings. And if we take a population approach, within England we've got a good 500,000 plus people with severe alcohol dependence who are kind of in the community. Very few of them access addiction services because they may not want to. And I think the thing that changes is the risk benefit in terms of what we need to consider as clinicians and as services in terms of the advice that we offer people during the COVID pandemic, just because of the change in context. So specifically for patients with alcohol, on the one hand, you've got people's reduction potentially in terms of being able to access alcohol. That may be variable. They may be self-isolating with family members who say, right, you've had your last drink, stop now. And they may also be running out of finances. So people who may otherwise be choosing to continue to drink may suddenly be needing to stop drinking. And so where we started with this was this sense of how can you offer people kind of safe advice of doing that when at the same time their likelihood of being able to access community services is also going to be reduced. And people's default option tends to be to turn up in the emergency department in alcohol withdrawal, but they're not doing that at the moment because they're worried they might get COVID. So that's helpful, but also they would get a less targeted care if they did. So, the whole risk benefit had slightly changed and we wanted to do something about that. So within NHS England, there's some specialty advice that's now been published and the link is there. And that's really trying to kind of harness the non-specialists, in mental health services and acute trusts with an alcohol lead. So to try and just get people to step up and be an alcohol lead such that we can then kind of share good practice, share protocols, kind of get, at scale, some quite simple things out there that may really have an impact at a population level, and to come up with some patient-facing kind of harm minimization advice, where normally we would say to people, carry on drinking at the level that you're drinking and go off and see your community service. That may not be possible for people. So what we're trying to do is kind of say, well, if you are needing to stop, if you are needing to reduce, this is probably the safest way that you can do it. Hopefully you can still get some access and support from your community service, but that is by no means guaranteed, because their focus is very much on OST at the moment and the opioid kind of crisis that has been mentioned thus far. But it does mean that the alcohol patients, in terms of having access to detoxification, is also limited. So there's some really good in both Scotland, the SHAP advice, the Royal College of Psychiatrists. My colleague Anne Lingford-Hughes just written some very good advice for that, which is going up shortly. And so that was really something, and hopefully ISAM can help us with anybody who wishes to be an alcohol lead as part of our kind of collaborative. That would be great. Thank you.
Thank you very much, Julia. Now the next speaker would be Joe Tay. Joe, are you available right now online?
Yes. Yes, I am.
Please go ahead. I do not have your name here. You can just provide with your complete name and your affiliation.
Of course. So my name is Joe Tay. I'm a GP with a special interest in addictions, working in Edinburgh. So thank you very much for the opportunity to speak a little bit about homelessness and the COVID outbreak as well. I put one slide up, which will hopefully give a general idea of exactly how complex this is. I'm sure all of us know this already. But essentially, what we have is a syndemic. Quite often we see homelessness together with IV drug injecting, hepatitis C, HIV transmission, transactional sex work, sexual violence, violence in general. All of this forms a reinforcing syndemic, which when it collides with something that I would say pretty much all of us perhaps have never experienced firsthand, the pandemic, what is this going to be like? And the answer really is we don't know. We can only guess at it, and indeed that's what I'll be talking about a little bit today, is the strategies that Edinburgh has undertaken at the moment to try and address this huge unknown. I should emphasize here that I'm describing other people's work as opposed to anything that I've planned. A lot of it has been based on people who've been tackling crises really for decades. So it's important to remember that our third sector partners who've worked with homelessness and people who are homeless themselves are constantly firefighting every day to earn an income. Our third sector partners are tackling, trying to find appropriate accommodation for people who are struggling. So in a way, it was unsurprising that they came to the fore really rapidly and managed to negotiate with a number of our vacant hotels to provide immediate housing for people who are street homeless. So, for example, Streetwork were able to find homes for roughly 150 people within 4 days. A vital component for what is to come, the need for social distancing, self-isolation, cohorting, all these recommendations for people in general, which of course, as we know, would have been impossible for people who are street homeless if not for this particular intervention. And we're also worried about excess death among our homeless population due to the pandemic. When people are unable to source their usual drug of choice, will they increase their unsafe activities? With reduction in face-to-face contact, will access to IEP or even testing for HIV, hepatitis C treatment, all of these things, if we don't have them at this time, will we be faced with really a rise in HIV cases, for example, which we will only identify after the pandemic is over? So these are things that we're thinking about, and these are services that we've tried to protect as far as possible. So now we have people no longer street homeless for now. We have them in purpose, a very suitable accommodation in many ways for self-isolation. So what are the problems that we now face? I think one of the biggest ones really remains access to services. And how we've tried to address that is by really being there at the both phase or cold phase, if you like. We have outreach clinics inside the hotel, for example. We've got an outreach nurse who has literally been going, walking the streets to identify people and asking them if they need OST and registering them with our homeless practice and getting them started. Her famous story is of doing this for someone in the graveyard not so long ago. And we are trying to remove any and all barriers to accessing this treatment. We're looking at people who will struggle to have an income and therefore provide themselves with alcohol. We're trying to see if we can fast track, for example, something that looks a little like a managed alcohol program. In terms of being where people are, the key thing there is we're finding that people may not necessarily seek OST right there and then, because to be honest, in Edinburgh, it feels a little bit like the calm before the storm. But if they see you there every day, obviously with your protective clothing and distance of 2 meters, then it's their opportunity to build, or your opportunity to build a relationship with them, but also to provide a little bit of reassurance that we are there to catch you if you start to withdraw. And the hope being that if we can do this well, we will, stop the need for sort of risky behaviors and things like that. Am I doing okay for time?
Yeah.
Yeah. So, okay, great. Thank you.
Thank you. Thank you very much. Okay, the next speaker, Christian, are you online?
Yes, I am.
Okay, good. Go ahead, please.
Thank you. Yes, my name is Christian Olvik. I work at Norwegian Directorate of Health, which is responsible for making, amongst other things, national guidelines. And we're currently facing, of course, the problems with COVID-19, and to update our guidelines to ensure both a good service for the substance use disorders and at the same time for handling the COVID-19 situation. First, I briefly just supplement Fateme's presentation about the present situation in Norway, and then some of the measures already taken, and then move on to what challenges we are facing on a guideline level, and then some considerations and possibilities to solve these challenges. So at the present, we have seen a large-scale reorganization of our services, especially the low threshold facilities. When they're closed, have increased their outpatient treatment services so that they still are able to provide the people in need of clean syringes and food, and also naloxone and so on. And we have also managed to still provide necessary medication in OST for the OST patients. As others have pointed out, there has also been a change in Norway concerning how the OST is provided, with more take-home doses and less supervised urine tests, and an increased focus on low-threshold OST in order to reach out to more opioid-dependent persons that are currently not enrolled in the OST program. So that has a very high priority in Norway, to reach out to those in need, opioid-dependent people. So what challenges us at the moment is also which further measures should we take in order to prevent spread, transmission of COVID-19, and especially then amongst people who use drugs, because of course we fear the consequences of such an outbreak. And in that respect, we have a special legislation in Norway, COVID-19 legislation, which has regulations about how one should live up to the rules of quarantine and isolation. And one risk also being prosecuted and being isolated against one's will if one cannot comply with those regulations. We're not sure if that, of course, will be actually carried out in real life, but it poses some difficult questions at the guideline level, which one of those is how to address people, the various addiction states that people have, like addiction to benzodiazepines, amphetamine, alcohol, and so on, when their craving is what will potentially make them leave their home or where they are during their isolation, and thereby breaking the rules. So how far should the service go to provide them with additional substitution treatment besides the opioid substitution treatment, then benzodiazepine and also amphetamine, which in Norway, as in many other countries, are used currently for the treatment of ADHD. So that is a kind of a discussion going on in Norway at the moment to address and to try to avoid a major outbreak of the COVID-19 among people who use drugs. Thank you.
Thank you, Kristen. Thank you very much. Alex, we received kind of questions regarding the ISAM PPIG survey. Would you just give people kind of an idea for 1 minute, and that would give me 1 minute time to just update Nestor's slides?
Can we finish the special issues? We have another presentation from Nestor.
Yeah, I need 1 minute to kind of update Nestor's slides, so I'm just going to use that one.
Oh, I see. Okay. It's a divergent technique then. Yeah. Okay, thank you very much for putting me on the spot. Yes, so essentially, as I think most of you already know, that the Practice and Policy Interest Group are conducting a global survey, and this started as a result of most of the PPIG members being involved in the publication, the manuscript that was published on Easter Sunday, last Sunday, and realizing that actually we were talking about our own experiences, but we never really had the time to ask other people, other practitioners, what their experiences are. And the challenge, of course, is always there when you're trying to do something global or something beyond your national boundaries, is to how do you assimilate that. So PPIG quickly formulated, thanks to Ali and Ramin, Parnian, Hamid and other people, formulated this global survey. And we did actually send it. We have a database of around 5,000 practitioners worldwide, plus 5,000, including the ISAM membership. And interestingly enough, and we are all very busy, and when we always say a survey always takes no more than 20 minutes, we get really, really cautious about it. But please, if you and your colleagues actually can spare the time to fill in the questionnaire, the more opinions we have, the more we learn. And this is more really for an intermediate long-term basis, so that when and if we are in a similar or quasi-similar situation, we know what the challenges were and what good practice was. And that would complement the surveys that the UNODC, WHO, EMCDDA, and other international bodies are doing. So please do fill in that questionnaire ASAP. We intend to close our first call by the end of this week, so that then we can repeat the questionnaire again every month for the next 4 or 5 months to the practitioners who have replied to the first call. So thank you very much. Is that, Hamid, is that enough? Was that enough?
Yes, thank you, Alex. And everybody, you can imagine that how working with Alex, with his passion and his leadership, is an enjoyable act. So, Alex, thank you very much. And to be honest, right now, just for this series of webinars, Alex was the main person behind all the scenes, supporting all of us to put those things together. So many thanks to Alex for his leadership. Nestor, we are ready for your talk.
Yes, morning. Thank you, Ahmed. Thank you, Alex, for this kind invitation. It's a pleasure to be here. I think some of you know that recently the WADD, the World Association on Dual Disorders, Addiction and Other Mental Disorders, has released a statement with the focus on patients, of course, with dual disorders during the current pandemic. Why? It must be recognized that patients with dual disorders have clinical and behavioral peculiarities that deserve our special attention. For that reason, we have written 15-point statement, but I have selected only 5 points for this talk that we would like to share with all of you. Next, Hamed, or next slide. Okay, as clinical care expert in the area of dual disorder, we have a unique role in reducing not just the viral infection, but the risk as their psychopathological disorders worsen. They may, as Nora say, they may be discriminated against, blamed, and abandoned. Due to seclusion, patients with dual disorders may face difficulties in acquiring substances, legal or illegal, which may trigger not only withdrawal syndrome, but exacerbate their other psychiatric disorders, such as psychosis, depression, anxiety, and of course, suicidal thoughts. Patients with dual disorders are more likely to smoke, much more than general population, as Nora said also, possibly placing them at a higher risk for more severe morbidity and mortality, but also at the risk that nicotine withdrawal will worsen their psychopathological disorders. Even more, it's probably that nicotine increase hemoglobin rate, perhaps having, in this regard, a protective effect for patients with COVID infection. Next slide, please. Okay. Patients should be reminded that in case of requiring an admission due to COVID infection, they must identify themselves as patients with dual disorders and their needs of specific medications in addition to anti-infection procedures. We can think another clinical situation, for example, patients who are taking clozapine, the well-known antipsychotic drug, and the interaction between clozapine and the infection and some of the drug that we are using for the infection. Finally, we must continue to insist to health authorities and policymakers that the integration of the dual disorders patient into a unified mental health network within a public health system is absolutely necessary. Thank you for your attention.
Thank you, Nestor. Thank you very much. Okay, the last part of the webinar would be question and answer and how we can share other experiences from people that are attending the meeting. So, and the chairs would be Kathleen Brady, ISAM President, and Alex Balluccino, ISAM President-elect. So, Kathleen and Alex, you can kind of manage the questions and the conclusions that you want to put together. And meanwhile, I would like to kind of ask participants to see the chat area. There is a chat area in your software, so you can put your questions in the chat area if you want to share the questions. And also, speakers could see that there are some questions there, so people can pick up the question that they want to answer. So, Alex and Kathleen, we are with you.
Yes, unfortunately, my chat area just disappeared. I'm not used to using this particular program, so I'm trying to get that back on again.
Okay, so I'll
yeah, you can maybe.
Kathleen, I'll start then, and because my chat area is functioning. I'll just start with actually Ian Smith's comment. I don't know if Ian is still around, which ties very well with Nestor's presentation. Hello, Ian. Hi. With Nestor's presentation around, how well are people working jointly with the rest of the mental health services, and I'm going to put that to the 141 participants here. If there's been any experiences, positive or negative, around that.
Sorry.
Do you want me to say something, Alex?
If you want, yeah, I was, yes.
In Scotland, we know a lot of addiction beds have been commandeered by mental health services. Somehow the assumption was we would need less of these beds, but also because administratively we are underneath mental health. So we're a kind of poor cousin within these organizations. So I know one of the Glasgow wards was commandeered, and the Edinburgh ward, and our ability to admit in Stirling has been put on hold. And I mean, if I'm honest, I do find that stigmatizing towards our patients. And there's a lack of understanding of semi-urgent need for particularly alcohol patients to undergo detoxification. So that partly that's where that came from. But we also had Dr. John Mitchell beside our First Minister, Nicola Sturgeon, yesterday, big piece on mental health, not one mention of addictions as a form of mental health problem. So that's where my question came.
Any comments from the other participants around that? Is that something shared in other countries? Okay, anyone?
Can I say something? My name is Yasser Abbasi. Until 9 months ago, I was working in the UK in Liverpool, but I've started working in the UAE now, in Dubai. And over here, more so recently, we've seen a rise of number of cases, which has led to kind of a very similar experience to what Ian is describing, where the mental health presentations are seen as more urgent and more priority as compared to those presenting with substance misuse. We had an 18-bedded hospital with an 18-bedded unit within our hospital, which has been limited very severely. But we're trying to develop online models of recovery and rehab, which doesn't truly meet the entire needs of our patient group. But yet, because we work in an integrated fashion, those with dual diagnosis are still seen and addressed and admitted within a mental health ward with input from us. But those with pure addiction, those using excessive amount of stimulants or polysubstance misuse, are the ones who have started to struggle, particularly with the alcohol as well. I know it would be a surprise, but we do see alcohol dependence here, and the supply is severely limited with the lockdown. So the urgency or semi-urgency around that, it's still not clear, and acute hospitals are also overwhelmed with presentations of other illnesses. Hence, it's an evolving situation, which I think we will start seeing ramifications in the weeks to come.
Yeah, I think that crystallizes, I think, what most practitioners are feeling right now. Sometimes we have less answers than what we usually have, and we wait for these either ramifications or for time to tell us what would be the best strategy to resolve these things. I'm getting chats here as well around the issues of inpatient treatment, either within mental health or not. So who wants to...
Can I make a comment?
Yeah.
So look, it's in New Zealand, I think we managed to flatten the peak. And so we're not experiencing a need to prioritize beds. However, we're not seeing any difference between addiction beds or mental health beds. Both parts of the service are mainly provided in the community. So we're actually we have empty beds at the moment in both mental health units and addiction units, because we're trying not to use beds as much as is possible. But there is no difference. I mean, they're both treated equally.
That's interesting. That's refreshing to know that. Okay. Hamed, questions? Other questions? Which one?
You have a question from Oslo. Gabriella.
I was just going to say, I'm on my, I found the chat box, and I think that Gabrielle wanted to tell us a little bit about how things are going in Oslo.
Yes, I'd like to do that.
Okay.
It's nice to see so many friends from the national community, and this is a really great session. I have presently gone back to clinical work after having been working, as Kirsten is doing now, in the directorate for many years. And I'm presently working at the municipality clinic for COVID-infected individuals in Oslo. We have just received our first 2 patients, and unlike our expectations, they were not opiate users. They were users of cocaine and alcohol, actually. And they come from a minority group. But one of the issues I wanted to raise is that I have a concern if we're really reaching out to the people we should, because I think they have a long, they know that when things are happening to this group, that we might use compulsory measures, like Christian said, we are able to use for our drug users. So I think there is a fear in the group we're trying to reach that if they test themselves, they might be compulsory admitted to our clinics. So I think we have a big, and I heard some of the same words from New Zealand. So I think that if we are sort of talking a lot about compulsory measures, we will not reach them. In our clinic, we are trying to reach out and say that we'll give you whatever treatment you need. We'll give you proper treatment for detoxification if you want that, and we'll give you proper treatment for whatever addiction you got. But I think we should maybe try to get some questions out to the people in the street to see why they're not testing themselves. So I think we need to do that in order to get to reach the people. Thank you.
Okay, and I think that was a question by Joe Tay about compulsory measures in Norway. I think you've explained that, and that's something that's not necessarily common in other countries when you talk about compulsory measures. Gabrielle, can you explain a little bit on that?
I can say something. I mean, we have this corona law, which Christian said something about, which makes it possible to put people who don't, who are in the danger of spreading the virus. We might put them into our ward compulsory. It hasn't happened yet, as far as I know, Christian. But we also have in Norway a law for compulsory treatment of drug users, which is not very much used. But I also think that this might be a fear among the people in the street, because those are the people we want to reach, really. Is that well enough explained?
Yes, yeah. Thank you, Gabrielle. Thank you.
Okay.
Could I make a quick comment, actually, on the back of what Gabrielle said? Hi, it's Joe Tay here again. It's interesting what you said, Gabrielle, a minute ago about people declining testing, because we had that for the first time yesterday. 2 people who were suspected COVID, whom we wanted to test, so that we could say to them, well, now you can just leave self-isolation. So there was a disputable commitment to self-isolate and a definite decline for testing, which is a first for us. And we are struggling to understand what is behind that. So yeah, that's it.
Thank you. Kathleen?
Yes.
Yeah. Do you have other questions there that were on the chat line, on the chat room?
Yeah, well, I think somebody brought up the issue of testing, and I'm just wondering from the group, how available is testing, COVID-19 testing for our patients? Has that been a problem for folks? It seems like that is sort of the universal problem.
We in Edinburgh, we've got a 24/7 community COVID testing service now. It's only just become 24/7. It was just during working hours until a couple of days ago. We have no idea if we're going to be overwhelmed or not, but at the moment it's functioning and it's available.
Do people need to be symptomatic? Do you need to be symptomatic or?
Yes. Oh yes, yeah. Pardon me, I should have specified that. Yeah.
Yeah, that's generally the way it is here, is that people need to be symptomatic or have a known exposure. That's very clear.
That's right. Yeah.
Yeah, and then
add something.
Sorry, Gabrielle.
Yeah, because one of the problem is that the drug use itself might mask a lot of the symptoms of the COVID-19, and so might also abstinence symptoms. So I think these people might, or our people might not experience the symptoms in the same way as the rest of the population because of the drug use, basically.
And it's a very important question, because there was someone else who put in the chat room as well, is what happens after COVID-19 and after the lockdown is off, and would you be using testing in order to go back to your usual normal routine when it comes to patient interactions, etc. So those are questions I don't think people or countries have actually reached that situation unless we have someone from Denmark, who's a country which seems to be going in the right direction.
Okay, well, yes, I'm on it. We locked down about 11th of March when there wasn't that many cases, and by now we have opened the country up a bit, and the main thing seems to have been that everyone has kept at a distance, and they have calculated that currently the transmission rate is 0.6, meaning each person with the virus will on average transmit to 0.6 persons. And so it seems that in overall, people have understood that everyone needs to keep a distance. And well, most of my patients are sort of behaving, and we are testing, and so we are coping. Of course, we know when we open up again, as we've started, we might get more cases, but overall, the government says that our approach has probably saved quite a few lives. So, yeah. So our Prime Minister said that Denmark had done well because people had actually understood social distancing. So, yeah.
Thank you very much. Thank you.
In New Zealand, we're also thinking of potentially we might be out of the lockdown by next week. And like Denmark, we acted early. And we're thinking of these novel models of care that we've developed. We're looking to find ways of actually keeping these models of care rather than going back to the usual face-to-face.
Yes, same here in Denmark. I had a talk with a patient over Skype who's in another part of Denmark, and of course I'll continue that after the lockdown, because then I can keep in touch with him more than over the phone. It can be over Skype. So yes, that's an improvement that we've got these possibilities now.
And
they're more cost effective as well. So, yeah.
And can I ask, is there anyone from China who might tell us more about this? No. Okay. All right. We'll make sure that they will be present for the third webinar. Yeah.
Alex, we do have a question from Gregory Bunch, who wants to ask about advocacy priorities for ISAM. Gregory?
Yes. Do you hear me? Can you hear me?
Yes.
Yeah. Okay. So for Dr. Baldacchino and Dr. Brady, I'm anticipating, well, I'm here in New York, we're really getting hammered, both from a patient treatment perspective and the patient's also workforce perspective. We're really getting hammered with the workforce. A lot of the people are not coming into to the clinics because of the concern, and administratively, we're getting hammered economically, and we'll have to lay off people in the time of the greatest need. I anticipate, from my perspective in New York, that will continue until we get a vaccine, and which could be a year. And I anticipate also that the economic and socioeconomic fallout from the coronavirus will lead to a crisis in addictions rising. And we're already seeing that in New York. That will be unprecedented. And our governor in New York has announced that there will be draconian budget cuts because our expenses are way up in the state. Our revenue is way down because of those. I'm getting interference. And the question is, what do we need to do from the leadership in ISAM to advocate for the appropriate support for addiction treatment? And I'm forecasting that if we don't get a strong message out to the leadership in the country and around the world, that if we don't support and fund addiction treatment properly, we're going to have a second tsunami, second and third wave of the tsunami that's going to be worse than the consequences of the coronavirus. In other words, we're going to see more deaths and more problems with homelessness, poor sanitation in communities, with individual families and communities, more problems than we're seeing with the actual consequences of the virus. And if we do not act assertively with strong leadership for advocating for the appropriate funding and resources for addiction services, prevention, research, and treatment, I anticipate that that will be at the peril of the leadership of the world, and we need to make that message clear to policymakers and the leadership, because we in the United States are now throwing trillions of dollars of federal money at this problem of much too small of a percentage for addiction research and treatment. And I don't know how we get that message out, but I think it's incumbent upon the leadership, Dr. Baldacchino and Dr. Brady, to get that message out strong and do it proactively now.
Thank you, Gregory. And I think the responses to the global survey will help us to that, because if we have a response from more than half the countries worldwide talking about the reduction in treatment services, the reduction in support, as you have explained, I think that would be a very strong message to get it, over to policymakers and also to, readership. So thank you very much for that.
Yeah, it's a really good point, Greg. And I think, I think what we can do is come up with a very strong position statement that every one of us can use in our own countries to try to influence those policymakers and legislators that have the control of the purse strings at this time. So I think it is very timely. I love the piece that we already put out. I think we can take from that and add in information from this survey and develop something powerful.
Yeah, and this is something that we can work with the World Association of Dual Diagnosis, with EuroPed, with other organizations. The more practitioners saying the same thing, the better. And, it's a no-brainer with that. So it's an opportunity. Thank you, Greg.
Can I add something to that? This is Gabriella. I think it's a question of putting the right politicians in charge of nations. I think that this pandemic shows the great advantage of having a well-functioning national health system. And of course, it is the rich countries like Denmark, like Norway, like Sweden, like Finland, like UK, which will manage this best. And it's a great concern for the poorer countries in the world. and also for the countries like Iran in the US, where you have that president you currently have.
Okay, with that good notes, we'll hand you we'll hand you over to Hamed. Hamed.
Okay, thank you very much, Alex and Kathleen, for kind of managing the last panel. For the next step, we will have the third webinar in 3 weeks, in May 7th, and it's going to be on Thursday. So as you can imagine, as you can see that we are changing the days of the week that we are running the webinars to get sure that people who have a specific schedules, they can join in one of the webinars. So we have a sort of from Monday, now we are in the Wednesday, next one would be in Thursday. And we will put the recorded video of the webinar on the ISAM Neuroscience Interest Group YouTube channel. So please share the video with those who were not able to attend.